afternoon, everyone. Today we are going to talk about pediatric emergencies. This session will be recorded. The recorded version will be sent to everyone as long as you send an email to that email I have given in the chat box. So this is addressing like 6 or 7 topics. It's kind of hard to do within an hour or two. So I have made it very simple as possible, but the expanded version and the links have been given, the reference section. And if you need a PowerPoint, I can send it to you as well. And please share this information with others. So today we are going to talk about status asthmaticus, status epilepticus, shock, recognizing different types, respiratory failure, overdose, and diabetic ketoacidosis. First, status asthmaticus. First, assessment. It is better to assess asthma in an objective way so that there won't be any difference between one to another. It has been categorized into mild, moderate, and severe based on the scoring. Less than 3 mild, 3 to 8 is moderate, 8 and above is severe. The parameters we look at it is respiratory rate. The rate depends on the age of the patient, oxygen saturation before starting therapy, and auscultatory findings, and presence of retractions and how severe and which areas are involved, and dyspnea, whether they can speak in sentences or speak in words or can't able to speak. The first priority is assessing the asthma severity. So focus on HNP to confirm the diagnosis of acute exacerbation of asthma, determine the etiology, determine the severity, and estimate the risk factors for ICU admission. These are all the risk factors for dying from acute asthma exacerbation. These are all very important. If you see any one of them, be aware they can get severe or bad very soon, like previous severe exacerbations requiring intubation or ICU admission. More than 2 hospitalizations for asthma in the past 1 year. More than 3 ED visits in the past year. Using more than 2 canisters per month. Difficulty perceiving exacerbation symptoms or severity. Lack of asthma action plan. Currently using or stopped oral corticosteroids. Very important. Social history, low socioeconomic status, use of illicit drug and other psychosocial issues. And if they have an associated cardiovascular disease, chronic lung disease, psychiatric illness, and food allergy, again, the chances of getting worse is much greater. So what are the tests you need to order? The pulmonary function test, but in children, it does not give valid information because they can't get it done well. So if the child is less than 10 years, pulmonary function tests are hard to do, but the children more than 10 years old, one can do pulmonary function test. X-ray chest is not routinely indicated, but if the patient has first wheezing episode, asymmetric lung fields, unexplained fevers, lack of response to treatment, and critical illness, then X-ray is needed. Blood gases are not routinely indicated in acute exacerbation. These are all the considerations you do in pediatric population. The child is less than 1 year, the chances of the child having bronchiolitis is more likely. Age 1 to 5 years, classically underdiagnosed since they cannot perform pulmonary function test. Children with bronchopulmonary dysplasia, cystic fibrosis, and triggers for non-accidental injury can present as shortness of breath, So you have to be cognizant of how much from exacerbation, how much from underlying disease. Other important points to remember: the children between 2 to 15 years, 20% had or have associated mycoplasma pneumonia. If there is a first exacerbation, 50% of them have mycoplasma. So checking mycoplasma and treating in that age group may be helpful. In older adolescents, you should elicit the history for smoking, cannabinoids, opioids, withdrawal, and vaping. Not only it causes respiratory distress, it also worsens along with acute exacerbation of asthma. There are 5 goals when you are treating asthma. One is treatment of hypoxemia, early administration of steroids, administration of bronchodilators, administration of additional critical care medications, and regular reassessment for treatment response. We will go one by one. Hypoxemia prior to bronchodilator treatment is a marker of asthma severity. Baseline saturations less than 92 indicates the severity of illness is significant. The hypoxemia after 1 hour of bronchodilator treatment is a risk factor for hospitalization. Immediately after bronchodilator treatment, desaturation is expected. But if it is persist after 1 hour, the child needs to be admitted in the hospital. Second, steroids. Early administration of oral steroids within 1 hour of presentation reduces the need for ED presentation and also hospitalization. Mild exacerbation, oral steroids are not routinely indicated. In moderate to severe, oral steroids are strongly recommended. The duration of treatment is 3 to 5 days. The question is, what to treat with? Prednisolone or oral dexamethasone? The advantages of Decadron. It is long-acting. Half-life is 36 to 72 hours. 6 times more potent than prednisolone. The half-life of prednisolone is 18 to 36 hours. Decadron can be given single dose. Duration 1 or 2 days with dexamethasone, with prednisone 3 to 5 days. Decadron is not associated with vomiting. The question is how to give. To give by mouth, IV, or IM. The answer is, if the patient can take oral, that is preferred. But if the patient does not have an IV, IM can be given. But if the patient has an IV, one can give IV. The dosage of corticosteroids, prednisolone 1 milligram per kg per dose, the max 60 milligram. It can be given once or twice a day for 3 to 5 days. Decadron, it is given in moderate and severe exacerbations. The dose is 0.15 to 0.3 milligram per kilogram per dose. The max dose is 10 to 16 milligram. The dose is given 24 hours apart. Methylprednisone is typically given in patients admitted in ICU. The dose is 1 to 2 milligram per kg per day. Again, the max dose is 60 milligram. Solimedrol is given every 6 hours or every 12 hours for 3 to 5 days. The hydrocortisone is not routinely used in the United States. The primary bronchodilators used is albuterol when the patient is in home, and use MDI. But when the patient is admitted in ICU, typically we use nebulization. It can be intermittent, and most of the time they are severe enough to warrant continuous nebs. Other adjunct bronchodilators is ipratropium bromide. In critical illness, we give nebulized ipratropium bromide rather than MDI. And other adjunct is mag sulfate. Most of the patients admitted in ICU receive mag sulfate. The dose is 25 to 75 milligram per kg. Typically, we give 50 milligram. If you want to be cautious, you should give over 20 minutes because rapid infusion can cause hypotension. The way the MAG works by competitive antagonism for calcium receptors, it causes muscular relaxation. The side effects: hypotension, respiratory depression, facial warmth and flushing, muscle weakness, vision changes, and dry mouth. If you infuse over 20 minutes, usually you don't see all these side effects. Other bronchodilators. In United States, we have only these three apart from continuous albuterol, which we talked about. One, terbutaline. Terbutaline can be given subcutaneously. Most of the time, it is given in the pre-hospital setting. In critical illness, we give via IV. Even the dose is recommended is bolus followed by infusion. My practice is start infusion rather than giving bolus and infusion. The dose is wide, zero point 0.1 to 10 mics per kg per minute. I typically use the lower spectrum because it can cause cardiac ischemia. Next is epinephrine. Epinephrine often given as intramuscular, given in the emergency department and also in the pre-hospital setting, sometimes in ICU if the patient is so tight, couldn't able to open up. Ketamine is another adjunct, especially when you are treating exacerbation with BiPAP. The ketamine not only helps sedate the patient, it also has bronchodilator effect, and also it is sympathomimetic. And there are side effects one should be aware of. It can cause hallucinations, especially in adolescents, and it can cause laryngospasm if the patient has a preceding URI symptoms, which often in acute exacerbation you would come across. So be aware of laryngospasm, increased secretions, and hallucinations. How often you need to reassess? 1 to 2 hours after short-acting beta agonists and 3 to 4 hours after corticosteroid administration. The next topic is status epilepticus. It is a life-threatening emergency characterized by prolonged or recurrent seizures without recovery between episodes. The prompt treatment can prevent neuronal injury, morbidity, and mortality. There are two important time points one should remember. T1 is called when the seizure activity terminates. T2 is the time at which the long-term consequences might occur, including neuronal injury, alterations of neuronal networks, or death. For tonic-clonic seizures, the T1 is 5 minutes. That means if the tonic-clonic seizure lasts more than 5 minutes, it's called status epilepticus. If the seizure lasts more than 30 minutes, it causes neuronal injury by itself. In focal seizure with impaired awareness, the T1 is 10 minutes, T2 is 60 minutes. In absence seizures, T1 is 10 to 15 minutes, the T2 is unknown. So why the status epilepticus happen? Either because failure of inhibitory pathways or hyperactivity of excitatory pathways, which leads to neuronal damage, cell death, and alteration in brain networks. The seizure lasting longer than 30 minutes causes neuronal damage with self-perpetuating dysregulation. The important point to remember in status epilepticus is if the seizure lasts more than 5 minutes, there is internalization of GABA A receptors happens. That receptor is responsible for containing seizures when you give benzodiazepines. So giving benzodiazepines more than 2 times is not going to work because the internalization of GABA A receptors happens. Status epilepticus leads to increased epinephrine and norepinephrine levels. It causes vasoconstriction, and decreased perfusion and oxygenation in the muscles in the brain, causes cyanosis and decreased oxygen saturation. And eventually, it can lead to cardiovascular collapse after 20 to 40 minutes of convulsive seizures. This was an important study published in 2012 in New England Journal of Medicine called RAMPART trial, the rapid anticonvulsant medication prior to arrival. It's a randomized double-blind non-inferiority trial comparing intramuscular midas versus IV lorazepam. What they found was it is a non-inferiority trial. In spite of that fact, intramuscular midas worked much better. It stopped the seizure in 73.4% compared to IV lorazepam, 63.4%. The dose they used, if the child is or the patient is more than 40 kilograms, they used 10 milligram intramuscular midas and 4 milligram IV lorazepam. If the weight is less than 40 kilogram, 5 milligram intramuscular midas and 2 milligram IV lorazepam. My thinking is putting an IV and giving lorazepam took longer time than giving intramuscular midas. That could be the explanation for better response with intramuscular midas. Nevertheless, it is a non-inferiority trial. So what to do when the patient presents with status epilepticus? Early IV access and get the labs done and identify the treatable causes of seizures like hypoglycemia, hyponatremia, and hypocalcemia. That is number one, needs to be identified and need to be treated right away because it will prevent the prolongation of seizures and also ensuing status epilepticus. So how to treat? The treatment regimen for status epilepticus is time-bound. The first 5 minutes, you need to contain the seizures. Longer you leave, harder to control. The first dose you would use is IV lorazepam. If the IV is not available, use intramuscular midas. The dose is IV lorazepam 0.1 per kilo, max 4 milligram. Repeat in 5 minutes. The max dose is 8 milligram. For intramuscular midas, 10 milligram if the weight is more than 40, if it is less than 40, 5 milligram. When you do that, during that time, automatically assess airway breathing and circulation and administer D50 in adults if the sugar is less than 60. In children, you don't use D50. Instead, you use either D10 or D25. When you use D10, you use 2 to 4 ml per kilo. When you use D25, 1 to 2 ml per kilo. And also be aware that it could be the manifestation of stroke. So neuro exam and looking for stroke. If you have any suspicion, go ahead and activate the stroke team. If the seizure doesn't contain in 5 minutes, then second line of anti-seizure medications need to be given. Some people say, even if benzos contain the seizures, go ahead and give the initial other anti-seizure medication, like IV Keppra. Dose is 60 per kilo, max 4.5 gram. IV Phosphonatine, 20 per kilo, max 2.5 gram. IV valproic acid, 20 to 40, max 3 gram. IV lacosamide, 4 to 6 milligram per kilo, max 400, and IV phenobarb, 20 per kilo, max 2.5. Most of the time, we will give either IV Keppra or IV Phosphonatine. Just remember those doses. IV Keppra can be given fast, meaning you can push the dose. IV Phosphonatine, you cannot push the dose, but it doesn't have to be given over 20 minutes. The dose recommended is 150 milligram per minute. So whatever it comes. So you need to remind the pharmacist, you cannot run 20 minutes because the treatment is time-bound. Containing or controlling the seizures on time is very important. So while you are doing, automatically assess airway breathing and circulation. EEG need to be ordered and obtain CT head in appropriate patients. And again, when there is a stroke or suspected stroke, CT angiogram and CT perfusion need to be given. If the child is still seizing, or if the patient is still seizing, and it is based on whether the patient is responsive or unresponsive. If the patient is responsive, give another anti-seizure medications, not the same one you already given. For example, if you already given IV Keppra, use IV fosphenytoin. If you already given IV fosphenytoin, give IV Keppra, vice versa. If the patient is unresponsive, then your options are either to give propofol, Midas, and ketamine. When you're giving these medications, obviously you want to intubate the patient, and while you are giving or immediately before you give the medication. If the patient is still seizing, then call the critical care, neuro-critical care docs right away. Status epilepticus in newborn. They have a completely different. Number one, identification is difficult. Some of them just electrical seizures. You don't see anything clinically. Even if it is clinical, it won't be like generalized tonic-clonic seizures as we see in pediatrics and adults. They can have just purely motor, non-motor, or unclassified. It's different. So if you have any suspicion, go ahead and check glucose and electrolytes. Most of the time, it is issue with glucose and electrolytes that can be treated right away. The first line of treatment in newborn, that means children less than 28 days, is Phenobarb, 20 per kilo. If the seizure is controlled, the maintenance 4 to 6 milligram per kg per day. If the seizure persists, the next dose is Keppra, 20 per kilo. If unresponsive, then increase to 60 per kilo. And if the child does not respond to Keppra, then next line is fosphenytoin. And if it doesn't respond, next is Midas. And at that point, when you are considering phenytoin, consider pyridoxine at that point. The next topic is shock. What is shock? When there is a inadequate oxygen delivery to meet the metabolic demands, it's called shock. So DO2 is less than VO2. DO2 is oxygen delivery, VO2 is oxygen consumption. The oxygen consumption is higher. Oxygen delivery is lower, that is called shock. If you do not treat it, it will lead to metabolic acidosis, organ dysfunctions, and death. There are 3 stages of shock. One is compensated, meaning vital organ function maintained, BP, blood pressure remains normal. In uncompensated, microvascular perfusion becomes marginal, organ and cellular function deteriorate. The hypotension develops. Third is irreversible, when you develop multi-organ dysfunction. If you look at this picture, it is from hypovolemic shock. The vitals are maintained till you lose 25% of the volume. So having a normal blood pressure doesn't guarantee that the patient is not in shock. Typically, this patient will have higher heart rate to compensate for decreased cardiac output. So on physical examination, these patients will have fluctuating mental status. If the patient has open artery fontanelle, it will be sunken. On exam, you will see cool, pallor, mottling skin, and sometimes cyanosis, poor capillary flow, weak pulses, poor muscle tone. The patient may have tachypnea and tachycardia. It's very important, especially when you are dealing shock during winter time. Most of the patients are having bronchiolitis. Don't get fooled because of the tachypnea. Tachypnea can be a sign of shock. And they always have scant concentrated urine when you reach that area. There are five kinds of or five types of shock. I'm going to go one by one. One, hypovolemic, that is the most common worldwide. It's often caused by blood loss, accidents, hemorrhage. In our unit, burns, nephrotic syndrome, worldwide vomiting and diarrhea. It causes decreased preload secondary to the losses. The second kind is cardiogenic. It is because the pump failure secondary to myocardial function. You often seen in patients with congenital heart disease, cardiomyopathies, ischemia, and arrhythmias. Not very common in pediatric populations, I'm sure you see more in adults. Third category is distributive. Its abnormalities of vasomotor tone from loss of venous and arterial capacitance. You see in patients with anaphylaxis, neurological injury because of loss of sympathetic vascular tone following spinal cord injury most of the time. Sometimes drugs can cause distributive shock. The most common kind of shock in developed countries is septic shock. It can be sepsis can be from bacterial infection, viral infection, fungal infection, especially in patients with immunocompromised host. The septic shock has multiple forms. It can cause, there is a component of hypovolemia, component of distributive shock, and component of cardiogenic shock. Hypovolemia because of third spacing. Distribution, especially in early shock, what happens? The vasodilation causes decreased afterload. And also, sepsis can cause myocardial depression that can present cardiogenic shock. So you have to address all the three components when you are treating septic shock. Other uncommon, but it's very rewarding if you identify and treat it, is called obstructive shock. You see in patients with tension pneumothorax, pericardial tamponade, pulmonary embolism, anti-mediastinal mass obstructing SVC flow, and critical coarctation of aorta. It is decreased cardiac output secondary to direct impediment to right or left sided heart flow or restriction of all cardiac chambers. So how to treat? As I told you, there is oxygen delivery is lower than the oxygen consumption in shock. So first goal is increase oxygen delivery and decrease the oxygen demand. How do you do that? All the patients need to be on 100% oxygen. Fluid need to be given definitely for hemorrhagic shock or hypovolemic shock and septic shock and distributive shock. Temperature control, reduce the oxygen consumption. Antibiotics needs to be given, especially in septic shock, to contain the sepsis caused by bacterial or viral or fungal, and correct metabolic abnormalities. And oftentimes you may need inotropes, especially when you're dealing with septic shock and other types. In a patient with shock, make sure your ABCs are being taken care of. If the airway is not protected or couldn't able to maintain, the patient needs to be intubated. Always give 100% oxygen in patient with shock. And establish IV access right away. If you can't, do the intra-osseous access. So this is the algorithm how to do. Again, it's similar to status epilepticus. It's very time bound. Check the patient with the patient's mental status and perfusion. Begin high flow oxygen and establish IO or IV according to PALS. The patient does not have big hepatomegaly or bilateral rales or crackles. Give 20 per kilo of isotonic saline, and you can do 3 times up to 60 ml per kilo. If the fluid did not improve the perfusion, start inotropes, either epinephrine, norepinephrine, depending upon the type of shock. If the patient has a cold shock, titrate epinephrine 0.05 to 0.3. If you do not have epinephrine, you can give dopamine in those patients. In patients with warm shock, titrate norepinephrine 0.05 upward to reverse warm shock. And if you don't have norepi, you can start dopamine. The patient has a catecholamine resistant shock, consider hydrocortisone. Before you give hydrocortisone, always draw cortisol to make sure what is the baseline cortisol level is. If the patient has normal blood pressure, still the mixed venous saturation is less than 70%. Begin milrinone infusion to improve the perfusion. If the patient is in cold shock, meaning low blood pressure, mixed venous is less than 70%. Add norepinephrine to epinephrine to attain normal diastolic blood pressure. In warm shock, either you can add vasopressin on top of norepinephrine. If the patient is persistent catecholamine resistant shock, and look for pericardial effusion, pneumothorax, like obstructive shocks. And also sometimes when the abdominal pressure is more than 12, that can cause obstructive shock too. Those patients need to be opened up. If the shock is refractory and the patient may need ECMO. Even though I told you first fluid, epinephrine, norepinephrine, vasopressin, and stress dose steroids in the previous slide, that dynamics have changed the recent years. The current way of treating septic shock, start antibiotic right away, contain the fluid to 30 ml per kilo instead of 60 ml per kilo. Somehow in pediatric, it's not enforced strictly. In adults, pretty much they give 30 ml per kilo fluid bolus. Start norepinephrine right away because septic shock being the most common in developed countries in United States. And if it doesn't respond, epinephrine, vasopressin, very quickly. And metabolic resuscitation also can be given real quickly. The outcome is much better if you do back to back rather than like escalation therapy, what we used to do. Next topic is respiratory failure. By definition, respiratory system achieves two things: oxygenation and carbon dioxide elimination. So when there is a hypoxemia or hypercapnia, then by definition, the patient has acute respiratory failure. There are 2 million admissions per year in the United States. More than half of all patients admitted to the medical ICU, they stay more than 48 hours. In adults, the mortality rate is more than 33%. So these patients need to be evaluated quickly and addressed immediately. In pediatrics, the mortality rate is way lower. There are four types of acute respiratory failure. Type 1 is hypoxemic respiratory failure. This is the most common form, where the saturation is less than 60, not saturation, the PaO2 is less than 60 millimeter of mercury with normal or decreased PCO2. There are three dysfunctions that can cause hypoxemic respiratory failure. Either inadequately oxygenated alveoli, or compromised transition of oxygen from alveoli to the blood, or compromised ability of the blood to oxygenate. The inadequate oxygenation can be because your FiO2 is low or you are in high altitude, alveolar collapse, the presence of alveoli filled with fluid, cells, debris, blood, like aspiration, pneumonia, or pulmonary edema. The compromised transition when there is interstitial injury or pulmonary vascular disease. Compromised ability of the blood to oxygenate because of obstructed blood flow, shunting, low hemoglobin concentration, or dysfunctional hemoglobin. So type 1 being most common, you often see in patients with pulmonary edema, odds, pneumonia, interstitial lung disease, pulmonary embolism, pulmonary hypertension, atelectasis, alveolar hemorrhage, so on and so forth. Second group is type 2, hyperbaric respiratory failure or hypercapnic respiratory failure, where the sufficient amount of carbon dioxide is not eliminated. Carbon dioxide elimination based on minute ventilation. Minute ventilation is respiratory rate and tidal volume. When the minute ventilation goes down, carbon dioxide is not eliminated. As a result, you will have a hypercapnic respiratory failure. So, meaning there is hypoventilation, reduced minute ventilation. In what conditions you see type 2? When there is an airway compromise, CNS injuries, neuromuscular disorders, chest wall deformities. So hypoventilation causes hypercapnia. Third type is called type perioperative respiratory failure. Often is related to atelectasis of the lung. The type 3 respiratory failure has both hypoxemia and hypercapnia together. It can be prevented by elevating the head of the bed, early ambulation, incentive spirometry, avoiding excessive sedation, and lowering intra-abdominal pressure. The fourth type is high-demand respiratory failure, related to inability of normal or relatively normal lungs to keep up with increased ventilatory demands, often you see in patients with sepsis. The peripheral tissue demands cannot be satisfied by compensatory mechanisms. You see in patients with septic shock, hypovolemic shock at the extremes, cardiogenic shock, and hypermetabolic states. At the extreme, the consumption or the requirement is more than what the respiratory system can compensate. So how do you manage these patients? Again, ABC, airway, breathing, and circulation. Airway patterns needs to be ensured by positioning, suctioning secretions, treatment with bronchodilators, and placement of oral airway. Sometimes oral airway, especially when they are so obtended or you're thinking the patient is obstructing, put an oral airway or nasal airway in appropriate patients. When you suspect physical obstruction, do the laryngoscopy or bronchoscopy to remove the foreign body. When there is a severe respiratory compromise, invasive mechanical ventilation needs to be done. Endotracheal intubation. The endotracheal intubation can be oral tracheal, nasotracheal, sometimes cricothyroidectomy. In patients with GCS 8 or less, they need to be intubated to protect the airway. Monitoring and maintaining saturation is very critical during intubation. The breathing encompasses oxygenation and ventilation. Treating hypoxemia should be the first step in any acute respiratory failure. The oxygen can be provided via nasal cannula, face mask, venturi mask, non-rebreather, or high-flow oxygen devices. When hypoxemia cannot be corrected with supplemental oxygen or ventilation is compromised, mechanical ventilation, meaning intubation, is necessary. Mechanical ventilation can be, non-invasive or invasive. If the respiratory failure cannot be treated with invasive, non-invasive, the patient may go into ECMO. So even though it's a respiratory failure, circulations need to be maintained. Especially when you are doing mechanical ventilation, you are converting negative pressure thorax into positive pressure thorax. It compromises circulation. So treating hypertension in extreme and optimizing cardiac output is important when you are treating acute respiratory failure. So you need to choose the medications right, like anesthetics, sedatives, and paralytics. all can have hemodynamic effects. The last 10 years, the way we manage bronchiolitis have changed. As you can see, the usage of high flow nasal cannula is higher and higher over 10 years, followed by non-invasive ventilation, while intubated patients, ECMO, and low flow oxygen remain static the last 10 years. So, understanding and how to use high flow and other non-invasive devices becomes more and more important. The non-invasive mode can be CPAP, BiPAP, high flow, or RAM cannula. High flow nasal cannula. Why high flow? It works or it helps the patient by these 5 following mechanisms. Number 1, it meets inspiratory demands. Normal healthy volunteers take 30 liters per adult, 30 liters per minute. When you do high flow, it meets the inspiratory demand of the patient. When you have pneumonia or other respiratory illness, that peak flow goes 2 times or even 3 times. Second, decreases oxygen dilution, meaning when you are giving oxygen like 28%, with high flow, it delivers exactly close to 28% to the alveolar level. On the other hand, if you do not give the high flow, just increasing oxygen doesn't have that much effect. That is called oxygen dilution. High flow is lighter when compared to mask or something else on the face. Especially in smaller kids, they do not like having a mask on their face. High flow increases functional residual capacity, and it also causes dead space washout, meaning when you take first breath, you take oxygen in. When you breathe out, carbon dioxide out. When you do a third breath, you inspire 1/3 of what is being expired, meaning there is a carbon dioxide in it. When you do a high flow nasal cannula, that third breath will not have that much of carbon dioxide. That is called dead space washout. Okay, what are the parameters you set in? Start with 2 liters per kilo. The max is 50 to 60 liters in adults or in children. FiO2 to keep the saturation above 90%. How to go about it? This is from Lancet 2022. When the child is admitted to the hospital, commence low flow oxygen. The patient respond, titrate, and wean. If the patient is not doing well, and start the high flow nasal cannula at 2 liters per kilo, titrate FiO2. The patient respond, titrate FiO2 to room air. Once stable in room air, stop high flow. Do not titrate flow. If the patient does not respond, according to the 2022 Lancet, escalate to nasal CPAP. This is from London, so they do nasal CPAP. I personally do RAM cannula because RAM cannula pretty much American way of ventilation. So I like RAM cannula more than nasal CPAP at that junction. So what is RAM cannula ventilation? So you can do non-invasive ventilation, providing pressure control and pressure support without intubation. Without intubating the patient, you can adequately oxygenate and ventilate. The PAP recommended, peak inspirated pressure recommended is 20 to 30, 28 based on the paper, which I'm going to show. PEEP 5 to 10, again 10 based on the paper. Not much available, but this is the only abstract I could come up with. Respiratory rate based on the patient need and the age, FiO2 to keep the saturation more than 90. According to this paper, in the RAM cannula, they start with PIP and PEEP 28 over 10 and wean off when they go down to 26 over 8. National Children's, they use 30 over 10 then they wean up and they go down like 26/8. I just want to give you the ballpark where to start and where to stop the RAM cannula. Next is invasive mechanical ventilation. The reason for intubations are as follows. When there is a cardiopulmonary arrest, when there is a severe respiratory distress and hypoxemia is not able to be dealt with non-invasive or other devices. Severe acute respiratory distress, severe acute hypercapnic respiratory failure, severe refractory hypoxemia, severe refractory metabolic oxygen disorders, inability to protect the airway, meaning GCS less than 8, inability to clear the secretions, need for therapeutic hyperventilations like in patients with pulmonary hypertension, upper airway obstruction with poor airway patency, decreased respiratory drive with bradypnea like in narcotic overdose, severe trauma, surgery requiring general anesthesia. These are the indications for intubation. Intubation endotracheal most of the time. Before initiation, number one, assess the risk and benefits of intubation. Mechanical ventilations can be fatal sometimes and also life-saving. It can lead to significant hemodynamic compromise. It removes the patient's respiratory drive, so make sure you provide adequate support when you intubate. Changes in cardiac preload, afterload, and interventricular dependence happens when you convert from negative pressure ventilation to positive pressure ventilation. Negative pressure means what we normally breathe without the intubation. Before intubation, choose right sedatives and anesthetics. Secure vascular access. Prepare hemodynamic support. Adequately pre-oxygenate before you intubate. Prepare for supportive manual bag and valve ventilation because sometimes intubation doesn't go well. Upon intratracheal intubation, the tube position should be confirmed and secured to avoid accidental extubations. Both need to be done immediately after intubation. Monitor for patient comfort, gas exchange, mechanics, and ventilator waveforms, and provide adequate analgesia. And once a patient is on mechanical ventilation, spontaneous breathing trials should be initiated daily. With few exceptions, all those patients with intubation should have head and elevated more than 30 degrees. All the patients with mechanical ventilations need to have DVT, especially in children, prepubescent, postpubescent. Prepubescent, usually mechanical DVT is okay. If it is postpubescent, you need to give pharmacotherapy. What are the initial settings for ALI and ARDS? Tidal volume we choose is 5 to 7 ml per kilo of ideal body weight. Permissive hypercapnia, we don't have to have a perfect CO2. Initial PEEP can be 5 to 15 centimeter of water. And other parameters you need to watch when the patient is on ventilation is inspiratory drive and plateau pressure. The driving pressure has to be less than 15. That is the difference between PAP and the PEEP. The plateau pressure has to be less than 30. The driving pressure less than 15 has been correlated with mortality or improvement in the outcome. So keep that in mind. Next is toxidromes. We are going to talk about multiple toxidromes. We'll start with first anticholinergics. They have a typical signs and symptoms to identify which group of drugs the patient have ingested based on clinical signs and symptoms. The anticholinergics can increase the heart rate, increase temperature, the pupils are dilated, and decrease peristalsis and diaphoresis. They have dry mucous membrane, flesh, and urinary retention. Second, cholinergics. They will have increased peristalsis and diaphoretic. Excessive salivation, lacrimation, urination, diarrhea, bronchoria, fasciculations, paralysis. These are all you see in patients who ingest cholinergics. Ethanol sedative hypnotics. You come across this one very often because of alcohol intoxication or opioid. All the parameters should be depressed. Blood pressure will be lower, low heart rate, bradypnea, and temperature can be normal or low. Myotic people and decreased peristalsis, hyporeflexia, and ataxia. Opioids, similar. Low blood pressure, low pulse rate, low respiratory rate, low temperature. People are myotic, peristalsis will be low, hyporeflexia. Serotonin toxicity, blood pressure will be high, pulse rate high, and the other notable features are increased peristalsis and diaphoretic. Sympathomimetics, opposite of opioid. All these parameters will be high. BP will be high, pulse will be high, respiration will be high, and temperature can be hyperthermia. The pupils are dilated. Tremor, seizure, diaphoresis can be there on examination. Withdrawal from ethanol or sedative hypnotics may mimic sympathomimetic ingestion. So keep in mind, these patients are agitated, disoriented, and hallucinating. They can have tremor, seizures, and diaphoretic. Blood pressure, pulse rate, respiratory rate, and temperature all will be elevated. So how to treat these patients? Again, airway, breathing, and circulation. And also look for mental status changes. First, airway positioning. Sometimes you need airway adjuncts. Since it's overdose, airway adjuncts play a significant role. Once you open the airway, especially in opioid overdose, they may do well. Sometimes they may need endotracheal intubations and creating a definite airway. Then assess the breathing for oxygenation and ventilation. All the patients need to be on pulse ox and end-tidal CO2. Give supplemental oxygen, bag and mask ventilation, endotracheal intubation needed, and mechanical ventilation. Second, assess the circulation and perfusion. Clinical eval, all the patients need to be on cardiac monitor. Sometimes, well, most of the time, we'll end up doing 12-lead EKG for cardiac arrhythmias, prolonged QT interval, and prolonged QRS interval, and establish IV access and obtain blood for testing. And one should be proficient in CPR, fluid resuscitation, and antidysrhythmic therapy, especially atropine and bicarbonate. And some patients may need vasopressors and inotropes. Look at the mental status. Check the glucose. Check the temperature. Support oxygenation, ventilation, perfusion in altered mental status. And check for glucose needed, given dextrose, and Narcan need to be given. Some patients may need thiamine. The patient has the seizures, treat with benzos, pyridoxine, barbiturates, and propofol. Avoid phenytoin. The patient has hyperthermia, sedate the patient, cool the patient, intubate, and paralysis, and antidotes may be needed. Agitation needs to be treated with benzos or other sedations. Identify toxidrome. That will help you to give what type of antidote the child may need. History and physical examination, interpret bedside testing, and talk to the poison control center and treat the toxidrome with appropriate antidote. So when to admit ICU admission? Does the patient has any signs of serious end organ toxicity? Or the end organ effects progressing? Or the lab data suggests you have serious toxicity? So the patient has high risk for complications requiring ICU intervention. Seizures. unresponsiveness, level of consciousness impaired to the point of potential airway compromise, PCO2 more than 45, blood pressure low, cardiac dysrhythmias, abnormal EKG complexes, refractory or recurrent hypoglycemia. If the patient is at risk for complications such as aspiration pneumonitis, anoxic brain injury, rhabdo, or compartment syndrome. Does the patient has pre-existing medical conditions that could predispose to complications like alcohol, drug dependence, liver disease, AKI or CKD, heart disease, pregnancy, so the patient is suicidal. So these are all the indications for the patients to be admitted in ICU. Finally, diabetic ketoacidosis. Most of the patients come with the diagnosis of diabetic ketoacidosis. So I'm going to focus on treatment aspects. Careful fluid resuscitation, insulin administration, electrolyte replacement, and close monitoring for signs of cerebral edema. Cerebral edema is notoriously happen in children with DKA. Initial management includes fluid resuscitation with isotonic fluid. The fluid replacement should begin before starting insulin therapy. It's a very important point. The fluid can be half normal saline or normal saline or other solutions like lactate ringers, Hartmann solution, or plasmolite. My preference is normal saline, even though half normal saline will do as good as normal saline. So we use two bag method. The bag one has just normal saline with additives like potassium. Bag two, D10 with normal saline with additives, which is potassium phosphate and potassium acetate. So if the sugar is more than 250, we will give pure bag one. That means there is no dextrose in it. When the sugar drops down to 200 to 249, give 50-50, meaning it provides D5 concentration. The bag, number one bag will have just normal saline, another one has D10. When the sugar drops down below 199, so 25% from bag one, 75% from bag two, that gives 7.5% concentration. When the sugar falls below 149, 200, then predominantly you give D10 containing fluid 100%. By doing so, it is easily you can convert from 5 to 7.5 or 10% without ordering and reordering fluid from the pharmacy and avoid any kind of delay in the care. Using two-bag method, remove the wastage and remove the lag period, and as a result, the outcome is phenomenally great. How to do a rapid fluid administration. Always give, when this patient comes with DKA, they always have hypovolemia. So most of the patients need 10 to 20 ml per kilo of fluid bolus. Do not give more than 20 ml per kilo of fluid bolus because of the risk of cerebral edema. Since I told you, I personally use normal saline predominantly. When you use two-bag method, the amount of fluid you give is 1.5 maintenance. Invariably, these patients will develop hyperchloremia. Hyperchloremia can cause metabolic acidosis and low serum bicarbonate level. So how do you differentiate whether the acidosis is improving or the acidosis is developing because of hyperchloremia? Look at the anion gap. Anion gap initially was very high. That will become normal. The acidosis has not improved. If you look at the chloride, it will be higher. That's called hyperchloremic acidosis as a result of the treatment. It's insulin. Insulin infusion in DKA patients need to be given 0.05 to 0.1 unit per kg per hour. Insulin is very essential in stopping diabetic ketoacidosis. The way you might have seen the bag 1 and bag 2, we change without changing the insulin. Add more glucose as the patient improves, like that. Another important point is when you are giving insulin infusion, make sure the patient was on insulin pump that needs to be detached. Sometimes you will see the patient, you will be giving insulin infusion while the patient is already getting insulin via insulin pump. So make sure it is removed when you are giving insulin infusion. Other important thing to remember is potassium replacement. If the potassium is more than 5, delay potassium administration. If the potassium is 3.5 to 5, add 40 millimoles of potassium, often in the form of potassium acetate and potassium phosphate, 20 each. If the potassium is less than 3.5, start 40 milliequivalent of potassium replacement as soon as possible and delay insulin administration because insulin further drives potassium low. Usage of sodium bicarbonate. In children with diabetic ketoacidosis, there is a big no-no to sodium bicarbonate. Number one, it decreases serum potassium and cardiac consequences. And also it increases ketone production and it causes paradoxical CNS acidosis. The bicarbonate administration is not recommended in children because it has not shown any benefit. Bolus administration has been historically associated with bad outcomes, so there is strictly no bicarbonate administration. What about intubation in patients with DKA? Oftentimes, the patient comes with altered mental status, but we do not intubate. The reason being, intubation cannot match physiological minute ventilation, and it removes the respiratory drive and causes compensatory respiratory alkalosis, causes worsening acidosis. Then significant patient ventilator dysynchrony. It further accentuates cerebral edema in those patients who are already on in cerebral edema. So intubation, big no. Sodium bicarbonate infusion, big no. And insulin bolus is big no in children. These are the big no's. And also no big bolus, only 10 to 20 ml per kilo of IV fluids, initial bolus. In summary, in DKA, avoid rapid boluses of anything. Go slow. Severe the DKA, go slow. For example, start with insulin infusion. Insulin infusion is 0.05. Don't go above that. Avoid intubation. Fluid bolus 10 per kilo. Repeat if necessary. Same 10 per kilo. Rehydrate over 24 to 48 hours. And insulin is important for ketone clearance. Add more glucose, which we talked about in bag 1 and bag 2. This concludes the talk on pediatric emergencies. I know it's kind of hard topic to cover within the time period. Please shoot me an email. I will send you this presentation and also other PowerPoints and videos I have. Thank you all.